Hey, it's Dr. Sara Gottfried. I'm here in New York City. I'm here in my hotel room, as you can probably tell. And oh my gosh, I want to talk about cardiovascular disease because I'm giving a talk on it tomorrow on women and cardiovascular disease at the Integrative Health Symposium. And I just wanted to share some of that information with you. I have to say first, I had a PET scan today where they looked at whether I have amyloid beta accumulating in my brain and also how glucose is getting trafficked in my brain. And so I'll be talking about those results coming up very soon. But I wanted to share with you some of the highlights of my talk tomorrow in the hopes that we can work together to really reach more women and raise awareness about how women are differentially affected by cardiovascular disease. And I want to start first with what I learned 25, 30 years ago in medical school. And at that time, we were taught that if you're having a heart attack, which in medical parlance is a myocardial infarction, what you expect your patient to say is that they are having dramatic, crushing chest pain that's substernal in location, so right underneath the sternum, the chest bone. And it's radiating sometimes to the arm, to the shoulder, to the elbow. And so we were taught that's kind of the classic sign of a myocardial infarction. And it turns out that women don't have that as a classic sign. They sometimes do, but not like men do. So this is one of those cardinal differences between men and women, because women are more likely to have vague, non-specific symptoms, which then makes a lot of clinicians blow them off. And that's what we got to stop. So I want to talk about some of those non-specific symptoms. We'll start with that. So I've got a slide behind you where I'm looking at, some of the atypical symptoms that women have: nausea, vomiting, dyspnea, which is where you're short of breath, fatigue, like a profound sense of tiredness, unexplained weakness, generally unwell, pain in the neck or the upper back, or tightness or discomfort, a sense of foreboding. I think this is super interesting because we were always taught in obstetrics and gynecology that if you have a woman who's pregnant and she comes in, near term, and she has a sense of foreboding, like something is terribly wrong, you gotta listen to that. Women have great intuition about their bodies, and when they have a sense that something serious is wrong, you don't dismiss them. You really listen, and you search under, every rock. You look in every corner to see what it could be, including potentially ruling them out for a heart attack. Syncope, that's another one that I've seen in some of my patients that work with cardiologists and have cardiovascular disease. Another one is tightness or tingling in the throat, vertigo, dizziness. And indigestion sometimes can be relieved by burping. That's something that we see in a fair number of women. So since we had this idea that, everyone with a heart attack presents in the same way, and we've realized that that's not true, and it's led to underdiagnosis in women and increased mortality in women, we've made great strides. So you probably know about Go Red for Women. That's something that the American Heart Association put on to try to raise awareness about the differences of cardiovascular disease in women versus men. But I don't feel like it's gone far enough. I feel like we have to go much further, which is why I'm making some videos on this. And I want to make sure that you understand that 90% of women have at least one risk factor for cardiovascular disease. I talked about some of them in a previous video where I mentioned pregnancy is a stress test, and that means that women who have gestational diabetes and pregnancy-induced hypertension, preeclampsia, even preterm delivery, all of those can map to a greater cardiovascular risk later on. So there's others too. There's having a small baby for gestational age, and I imagine HELLP syndrome might also be associated with a greater risk, but I have to research that. Let me make a note. Here's the problem. We know that 45% of women identify heart disease as the number one killer in women and men. 45%. that's an issue because that means 55% of those women think that there's other problems that kill them, such as cancer, such as stroke, such as Alzheimer's disease. But it's heart disease that is the number one killer. And so we really need to raise awareness. It's hard to do that in a social media culture, in an attention economy, where your attention is being competed for by so many different entities. And so I hope we can break through some of that noise with some of these videos and with talking to each other and asking your questions. I'll do my best to answer them in future videos, so leave your questions below. So I believe we've got to revision the healthcare team that takes care of women, because traditionally that's obstetricians and gynecologists, people like me, who take care of women and are the primary care provider for women for a very long period of time. And then at some point, women start to go see an internist or a family practice doctor or some other type of practitioner. And that system of the obstetrics and gynecology silo and then sort of the adult medicine silo is not serving women sufficiently. So I mentioned already that 90% of women have at least one risk factor for cardiovascular disease. When you put that together with the fact that 80% of cardiovascular disease can be prevented with specific measures, and I'll make a video about what some of those measures are, like quitting smoking and changing your diet and sleeping more and getting the exercise that you need, stress reduction. When you put those two things together, the fact that 90% of women suffer from at least one risk factor for cardiovascular disease and 80% of cardiovascular disease and events can be prevented with starting with lifestyle medicine, personalized lifestyle medicine, that is a great opportunity to change the healthcare team for women, to think much more broadly. And I'm not going to mention everyone here, but I think we need to go beyond these silos that we have in obstetrics and gynecology and adult medicine. And we need to think about, okay, how can nurse practitioners help us with this? How can we provide more continuity? How can we train up the obstetricians, gynecologists so that they can address these risk factors that 9 out of 10 patients have? How can we get naturopaths and chiropractors and osteopathic physicians to join us in trying to raise awareness and to address these risk factors? Now, I read this really interesting article. It was in Circulation in December 2019, and it was by two presidents. The first was the president of the American College of Obstetrics and Gynecology. His name is Haywood Brown, a man. He joined with the president of the American Heart Association, a man named John Warner, to say that OBGYNs really must partner with internists and family practice doctors to address these concerns. And the point I'm making is we need to de-siloize and we need to go much bigger. We need to work together to collaborate and to address these problems that women have, because what we're doing right now is not working. Go Red for Women is a global campaign in 50 countries, and it's not sufficient. We need to do much more in terms of understanding what happens in women and why they're different and what we can do about it. So let me mention a few other statistics. We know that women are different from men on a molecular and a cellular level. I don't need to tell you that. I think you know that already. But here's some of the differences when it comes to cardiovascular disease. The first is our mortality is higher. So if you look at the population adjusted risk of cardiovascular mortality, it is 21% in women and 15% in men. Women are less likely to have their blood pressure sufficiently managed. In fact, more women are hypertensive over the age of 65. And if you look at older women and how many of them are sufficiently managed, it's only 29% of women versus 41% of men. Diabetes is riskier in women, so the cardiovascular mortality is higher, 19% versus 10% in men. And unfortunately, diabetic women are less likely to be treated for cardiovascular risk factors compared to men. One other study that's interesting is the InterHeart study, and that showed that psychosocial factors are more important in women compared to men. I feel like most women know this intuitively, but we know that the cardiovascular mortality for women associated with psychosocial factors is about 45% versus 29% in men. Now, here's the study that I think is the most important to pay attention to. If you learn nothing else from this video, this is the one I want you to take away. In 2018, in the Proceedings of the National Academy of Sciences, there was a landmark study that was done in Florida where they looked at ER patients who came in with a heart attack, with a myocardial infarction. And they did something super interesting. They looked from 2001 until, they looked over a very long period of time. I can't remember the exact dates. Anyway, here's what they found. Women who came in with a heart attack, if they saw a female physician in the emergency room, they had a 2 to 3-fold greater survival than if they saw a male physician. Whoa, that just blows me away. Now you might ask, okay, what about men? What if they saw a male physician versus a female physician? No difference in survival. So this is a gender bias that is affecting women who go to the emergency room, and it doesn't work in reverse. It doesn't work against men. So men do fine, whether they're seen by a male or a female physician, but because of some of these atypical symptoms that I talked about, it's harder to diagnose a heart attack in a woman, and female physicians are better at it, 2 to 3-fold better in terms of survival compared to male physicians. So I found that absolutely staggering. I think it's probably true for other outcomes, not just myocardial infarction, but this is one place where we have really good data. So Go Red for Women, it's raised awareness. I don't think it's gone far enough. I feel like we need more research on women. We need a different approach to the healthcare team that takes care of women. We need more women-focused care. We certainly need more women cardiologists. But beyond that, we need this much more collaborative and team-based approach to address these deficiencies that we have with taking care of women when it comes to cardiovascular disease, and to address this gap in terms of survival. So I hope this was galvanizing for you. I hope you'll share it with someone, since we know that 90% of your friends have at least one risk factor for cardiovascular disease. I hope you'll share some questions below, and I hope we can continue this dialogue. And let me know what else you want to hear about cardiovascular disease. I'll talk about some of the risk factors, because it's not just the simple risk factors that you probably learned about years ago, like, you know, smoking and hypertension and diabetes and sedentary living. It goes much broader than that. I think some of you were curious about some of the advanced blood testing you can do. I can talk about that. And I can talk also about, you know, why is it that we're seeing this greater risk in women beyond the difference that I started with, which is how women present when they're having a heart attack. So I hope you enjoyed this. I can't wait to talk about this tomorrow at the Integrative Health Symposium, and maybe I'll see some of you there. Okay, take care. Bye.